My name is Candace Roberts. I am an internal medicine resident at Washington University in St. Louis. I will be presenting a severe case of ALK inhibitor-induced organizing pneumonia. Anaplastic lymphoma kinase tyrosine kinase inhibitors, or ALK inhibitors, are used to treat patients with non-small cell lung cancer with rearrangements of the ALK gene. Second and third generation ALK inhibitors, such as alectinib and lorlatinib, were developed to demonstrate more potency and less resistance than first-generation drugs. Despite their potency, they have shown strong safety profiles when compared to other ALK inhibitors and standard chemotherapy regimens. In this case, a 64-year-old man with history of stage 4 lung adenocarcinoma with malignant pleural effusion, left hilar involvement, malignant ascites, and bone lesions, being treated with the second-generation ALK inhibitor, alectinib, presents with worsening shortness of breath for 1 week. The shortness of breath occurs at rest and is exacerbated by minimal exertion. It is associated with fatigue. Review of symptoms otherwise is negative. His past medical history is significant for pulmonary embolism, hypertension, and hypothyroidism. His home medications are albuterol, Lasix, Eliquis, Lipitor, levothyroxine, metformin, and melatonin. He has a 47-pack-year smoking history. He does not drink alcohol, and he uses CBD oil for comfort. His mother has a history of breast cancer and hypertension. His father had a stroke and hypertension. Vitals on admission were significant for an O2 sat of 88% on room air. Vitals otherwise were within normal limits. His physical exam was significant for cachexia, scattered bilateral crackles in the lungs, heard more in the left lung than the right, and 1+ pedal edema bilaterally. His lab values on admission were significant for a white blood cell count of 11.9, hemoglobin of 9.7, platelets of 663, lactate 2.1, NT-proBNP of 892, and an arterial blood gas with a pH of 7.48, PCO2 of 33, and PO2 of 59. His chest X-ray on admission, seen in Figure 1, showed widespread, variably sized pulmonary nodules bilaterally. His CTPE on admission, seen in Figure 2, showed developing and worsening patchy areas of coalescent parenchymal disease. Shortly after presentation, the patient had increasing oxygen requirements, leading to ICU admission for Optiflow. He was treated empirically with Levaquin, vancomycin, bronchodilators, and prednisone. His alectinib was held. He experienced gradual symptom improvement and was discharged with home oxygen and a prednisone taper. Follow-up imaging approximately 5 months after hospitalization showed continuing improvement of the organizing pneumonia, but an increase in the size of a left anterior pleural mass. He was started on pemetrexed to address this mass. 1 month later, he had worsening shortness of breath. Imaging at that time showed a left pleural effusion with no sign of recurrence of the organizing pneumonia, as seen in Figures 3 and 4. His symptoms improved with IV Lasix. He was then trialed on pemetrexed and docetaxel consecutively, and had continued improvement of shortness of breath, but experienced cancer progression on each drug. He was then transitioned to the third-generation ALK inhibitor lorlatinib, but soon thereafter experienced recurrent shortness of breath and fatigue. Imaging at that time showed new areas of reticulation and ground glass concerning for an inflammatory response, such as was seen with alectinib therapy. The lorlatinib was held, and he experienced rapid symptom improvement. This case illustrates that it is important to consider the diagnosis of drug-induced organizing pneumonia in any patient undergoing treatment with an ALK inhibitor, even if the drug has a favorable safety profile. In cases of pulmonary toxicity, prompt discontinuation of the drug can prevent severe, life-threatening conditions. A low threshold for discontinuation of alternate but same class therapy with recurrence of symptoms may also be warranted, as it was in this case.